I want to talk to you today about the British healthcare system, even though we're not anywhere near adopting anything like the British healthcare system, even though nobody here is going to be moving to England anytime soon. I think that this is important for us because there are so many proposals being made in the healthcare system that is before us right now. Things that are being winding through Congress, things that have already happened in Massachusetts. And a lot of them are based on ideology, they're based on theories or good arguments, but they're not necessarily based on a lot of experience. And so when we have these terms brought before us, single-payer systems, the government option or whatever that's going to turn out to be, accountable care organizations, which is a fairly new construct that is out there, medical homes have been promoted greatly. The role of preventive care, preventive medicine in our healthcare system, how much is enough? Is it going to save money or is it going to cost money? What is comparative effectiveness? Do we need to incorporate that into our system? And again, is it going to save money or is it going to cost money? And how is payment reform going to work into this? As I had an opportunity to study the British healthcare system, I found many comparisons there that I thought were relevant. And it's important because they've got 60 years worth of history. And I think that knowing what their experience is, to me, holds a lot more weight than working on the theory or ideology of consultants who have wound their way into Washington. Now, before I go over some of the details of this system and try to orient you to it fairly quickly, I want to give you just a note about the origins, because this is why the British healthcare system is unlikely to take its origin or to take off in this country. The countries really are different. We were at one time a colony of England, but the people who came to the United States risked their lives to cross the ocean to get away from England. And just because we're at one time a colony doesn't mean that necessarily what is a good fit for them will be a good fit for us. Now, if we look at England around the time their health system started, around 1946, here's what we saw. We saw a country in which people had huddled together in bomb shelters. Their homes had been destroyed by World War II. Every hospital in London had been bombed by World War II. All of the hospitals in the United Kingdom were in terrible shape. 50% of the hospitals in the United Kingdom had been constructed before 1890. There was a shortage of physicians. People were just coming off of rationing, and there was a desperation to just get something going. Emerging from these bomb shelters, emerging from these conditions, these people decided to begin a social welfare state, to take care of each other, to live and to do the best they could with the limits that were before them. They understood limits very well, and they just wanted to share and improve their lot. So on July 5th, 1948, ownership of all the hospitals in England and employment of all of the specialist physicians in England was turned over to the National Health Service. The general practitioners continued in their practices, but they all contracted with the National Health Service. That's where they took their origin. At the same time in the United States, people were coming home from the war. The Depression was ending. People were going to school on the GI Bill. Suburbs were building up. The economy was beginning to boom. The American dream for everyone involved was the achievement of the individual. And at that time also, words like socialism or communism were electric. Those were not good terms in this country at all. We were just around the corner from the McCarthy years. Anything that smacked of socialism or communism was not a good idea at all. And in the midst of this, President Truman and Congressman Dingell, who was the father of the current Congressman Dingell, proposed what at that time would have been Medicare for all. But the community as a whole, the physicians were against it, the society as a whole was against it by over 50%. It did not pass. And so they continued with a healthcare system that was evolving at that time, which was based on insurance that was provided by employers. So that's where we took our origins. Now, despite the fact that we feel that achieving the American dream is an individual thing, distrust of government is built into our genes in this country. If we look at the Bill of Rights of our Constitution, it does not define what the government should do for the people. The Bill of Rights defines how to protect the people from the government. And so with all of this happening, we still have to look at how we've evolved over that time. And despite our different images of ourselves, if we look at the percent of the gross domestic product of our economy that comes from government spending, in England it's about 40% of their economy is the result of government spending. In the United States, it's about 30 or 35% and going up right now. So despite our different images of ourselves, I think that time is moving us together a little bit, despite ourselves. Now, the National Health Service is not a simple organization, and I put this organizational chart up for you just to let you know that it is a fairly complicated organization. And if we look at the overhead of this system, it's about 5%. So it is less expensive to run than individual health plans in this country, which the not-for-profits are running an overhead in the vicinity of around 7 to 10% in this state at this time. So it is less expensive to run, but it's not a simple system at all. I will also have the private health care over here because that gets brought up so often. Private health care is only about 15% of the health care that's delivered in England. The vast majority of care is delivered within the National Health Service. And I'm going to go over these three boxes here, this National Institute for Clinical Excellence, right there, the Primary Care Trust and the Hospital Acute and Emergent Trust. Those are the key portions to this system, and that's where I'm going to focus my time with you over the next 15 minutes or so. So how do they get it done? Well, they have the central administration with regional primary care trusts, and 80% of the money flows through the primary care trust. This is a primary care centered system. They make the decisions regarding the distribution of money within the system. It is GP centered. Everybody has to register with a general practitioner. You are not in the British healthcare system until you've signed on with a general practitioner. And the general practitioners have their offices. They run private practice. They can make their practices small or large as they wish. They can employ other physicians to work with them. The average group size there is about 4. And they contract with the National Health Service. They are paid a fixed fee per patient. So when a person signs on with them, they then get a monthly fee to take care of that patient regardless of how often the patient is seen. The National Institute for Health and Clinical Excellence, one of the other boxes we saw there, is the equivalent of our FDA and National Institute of Health and Institute of Medicine and then some. This is the branch that approves drugs, reviews treatments, approves guidelines, renews the guidelines, has an evidence base for people, does comparative effectiveness, does cost effectiveness research, makes these guidelines available to the public as well as to the physicians. You can go to their website and look at their work as well. And then allows decisions to be made based both on the utility of a treatment as well as its cost effectiveness. If something is not felt to be cost effective, then they do not approve it. And the hospitals there are not paid fee for service. They're not paid fee for procedure. They are put on a budget. The primary care trusts look at their costs, put them on a budget. If they feel they need to expand, they have to justify it. If they want new equipment, they have to justify it. And what a general practitioner told me there is that from a point of view of electronic records or other technology, the hospitals are about 20 years behind the general practitioner's offices. They are run very lean in those hospital trusts. And roughly 20% of the trusts are in the red at any given time. About 5% of them are in the red most of the time. So there is not a lot of extra money there. The hospitals definitely aren't putting up billboards looking for more patients to come in. They are hoping not to see that many patients. The hospitals employ the specialists. So if you are a specialist there, you are working for a hospital. And the specialists are paid a salary. They are not paid fee for service. The specialists there work about 40 hours a week. If they take night call, they work about 12 hours on a shift. And the hospital, therefore, has an interest in how many doctors are trained, how many doctors are available in that area. They are not going to hire more doctors than are necessary to deliver the care that is necessary. In specialists, and how are patients treated? Well, access there is actually great for general practitioners. They do a lot of measuring within this system. And one of the things they measure is access. A standard to which the general practitioners are held is that patients should be able to get in and be seen within 1 or 2 days if they wish. And the success rate for that is about 70 to 75%. So access to general practitioners there is actually quite good. Not so much for specialists, though. The standard to which they have been held is 18 weeks, and it's moving down to 12 weeks. That is a access level that probably wouldn't stand very long in this country.